We'll start straight off. How do we define massive bleed in an ICU setting? Usually it's defined as loss of one blood volume within 24 hours. One blood volume being about 7% of ideal body weight in adults and 8 to 9% in children. The alternative definition is 50% of blood volume lost within 3 hours, or a rate of bleed of 150 ml per minute or more. Mainly, if we can look at the various causes of massive bleed, they are traumatic, upper GI bleed, lower GI bleed, bleed from the respiratory tract, coagulation disorders, which can be because of dengue, hematological malignancy, DIC, anticoagulant therapy, PPH, and of course one more, that is post-surgery. What are the priorities when we are faced with a patient with massive bleed? Well, first is restoration of blood volume to maintain tissue perfusion and oxygenation. And how do we achieve that? By treating any surgical source of bleeding, no matter how much fluids, blood products you push in. If there is an artery open or a vein open, only a surgeon can deal with it. There is no replacement for a surgeon. And then, of course, correcting coagulopathy by judicious use of blood component therapy. And one needs to protect the airway by intubation in variety of conditions, particularly massive bleed from a respiratory tract or upper GI tract, or a patient in shock, or a patient with altered sensorium, such as a patient who has come in after trauma. It's a busy slide. I'll try to basically put it out in short to you. First, how do we restore the circulating volume? Obviously, getting an IV line and a peripheral line with a 14 gauge larger is better than a central line. So don't waste time putting a central line. Give adequate volumes of warmed crystalloids. Colloids may be given, but there is the issue of coagulation profile being deranged by it. Aim to maintain a normal blood pressure and a urine output more than 30 ml per hour. There is no need to push the pressure very high, because actually very high pressure may sometimes cause more bleed. Obviously, measuring the blood pressure, heart rate, etc. gives us an indication, and a good history can sometimes tell us how much blood loss has been there. People have come out with good mathematical formulas, and one of them is something called a shock index, which is heart rate divided by systolic blood pressure. Normal is 0.5 to 0.7, and in significant bleeding it increases to 0.9 to 1.1. A rise in shock index correlates better than with early acute bleed as compared to any of heart rate, systolic blood pressure, or diastolic blood pressure used in isolation. So this is a good bedside way of assessing whether there has been a large bleed. Then, of course, we should not forget to keep the patient warm, and this is true whether a patient has come from a theater or has come from a roadside accident, or there has been a chaos in the emergency because everybody is trying to do everything at the same time, and patient often is lying exposed, and sometimes we don't realize that he's losing his body warmth. We need to quickly activate all the key personnel, and that could be intensive care team, could be the blood bank, could be the surgical teams, could be the radiology and imaging services. And of course, as I said, arrest the bleed. Now that could be a pressure dressing, that could be a surgeon coming in and ligating a vessel which needs to be ligated, or even taking the patient straight from the emergency to the theater. If the patient is bleeding in his abdomen after a bullet being pumped in, there is no point in wasting precious blood products and pushing one after the other. Quickly get in large bore cannulas in, fluids and some unit of activate the blood bank, get some products as soon as possible, and get the patient into the theater. Don't even wait to send the patient up to the ICU, which is a mistake often people make. Let's stabilize the patient in the ICU and then we'll take to the theater. The patient will never get stabilized. Then request for laboratory investigations. They don't go necessarily sequentially, they go one after the other. So when you put a wide bore cannula, you take the bloods straight away. So of course, full blood count, PT, ABTT, fibrinogen, blood bank sample, biochemical profile, blood gases, and of course, look for pulse oximetry. We need to repeat some of these parameters, maybe even 4 hours, or after 1/3 blood volume has been replaced. Repeat, of course, after blood components have been infused. How do we order red cells? Well, hemoglobin and hematocrit do not fall for several hours after acute bleed. I think most of us know that. Transfusion is rarely indicated when hemoglobin is more than 10 and is almost always indicated if it's less than 6. That's a rule of thumb. Uncross-matched blood group O negative, O Rh negative can be asked for in dire emergency, and not more than 2 units should be pushed in. If the patient is a male or a postmenopausal female, in such an emergency, in O positive blood can also do. And while this is being pushed in, we need to have an ABO ABO grouping done, and once we have an ABO, then an uncross-match ABO group specific blood can be then taken up for the next matching. And of course, full cross-matching is required if there are irregular antibodies present when time permits. Further time may not permit in an absolute dire situation. Further cross-matching is not required after replacement of one blood volume or 8 to 10 units of blood. Probably everything one patient has is washed off. Use blood warmer or rapid infusion devices if possible. Blood warmers are indicated if flow rate is more than 50 ml per kg per hour in an adult. And employ blood salvage methods if possible, but not if the area is contaminated. What about platelets? If it is more than 1 lakh per then we don't need to. And there are, if it is more than 1 lakh, we don't need it usually unless there is multiple injuries and which are likely to bleed, or there is a CNS trauma, or the platelet function is abnormal. So it's more than 1 lakh, patient is known to have CRF, we could still do with some fresh blood, fresh platelets. Otherwise, more than 50,000 is a good enough level to maintain. Anticipate platelet count if it's less than 50, and after 2 will need to be given after 2 or more blood volume replacement. So we'll probably need some platelets anyway. Aim of PT and APTD should be kept below 1.5. Anything more than 1.5 has been associated with increased surgical bleed. 12 to 15 ml per kg body weight of plasma is usually targeted, or 4 units straight away, roughly about 4 units of adult for an adult. And don't forget that it needs about 30 minutes of thawing time, plus the time of your blood sample reaching the lab and the lab starting the job for you. A quick phone call to the bank can often save 10-15 minutes of precious time. What about cryoprecipitate? If we replace fibrinogen and factor 8, if fibrinogen is less than 0.5, because that is associated strongly with microvascular bleeding. Fibrinogen deficiency develops early when plasma poor red blood cells are given as replacement. 1 to 1.5 packs per 10 kg of body weight should be given, and with the aim of increasing the fibrinogen levels more than 1 gram per liter. Allow for delivery time plus 30 minutes thawing time again. What about DIC? This is a deadly word, and there's a DIC scoring system which can help us in deciding if there is a DIC. I'll come to that as well, or maybe I can go to that one first and then come back to this slide. We look at platelet count, elevated fibrin-related markers such as D-dimers, prolonged prothrombin time, and fibrinogen levels. And all of them are scored as 0, 1, 2, 0, 3, etc. as you can see. And if the total sums up more than 5, it is compatible with overt DIC. Of course, we need to don't forget that situation can change, so sequential measurement and scoring may be required. How do we treat DIC? Well, first treat the underlying cause if possible, such as shock, hypothermia, acidosis, sepsis, etc. Component transfusions are reserved for patients with bleed, so one doesn't need to necessarily give the components just because the numbers are not right. If the platelets is less than 50,000, then yes, give platelets. If FFP is needed, if APTD, PT are deranged. Prothrombin concentrate, if available, may be used when volume is a concern. So we want to keep the volume low. But FFP as such, if volume is not a concern, then FFP is a better replacement, and cryoprecipitate may be given if fibrinogen levels are less than 1 gram. In DIC with predominant thrombosis, such as purpura fulminans, a continuous heparin infusion at should be useful. 10 units, I think that should be 10 units per kg per hour should be considered. In critically ill non-bleeding patients with DIC, prophylaxis, venous thromboembolism prophylaxis with either unfractionated or LMWX is recommended. Now, this is something we often forget. He is not bleeding and is critically ill. He still has a chance of developing a DVT and a PE. Severe sepsis with DIC, the recommendation is if the platelet count is more than 30,000, then one can consider using recombinant human activated protein C. And in DIC with primary hyperfibrinolytic state, one can use agents like tranexamic acid. Usually 1 gram every 8 hours is a good dose. And of course, we know mortality is high once DIC develops. An interesting agent which has been used in recent times is Novo-7, and we are all aware of it. It's essentially in presence of a bleed for various sources. This is an off-label use, and there is a national registry maintained by CMC Vellore Hematology Department. As of 2009, they had recorded 188 patients where it has been used in varieties of cases. To give you an example, in obstetric cases, the efficacy was 75% patients stopped bleeding and 75% survived the episode of massive bleed. In case of trauma, 74% patients the bleed stopped and 66% patients actually survived. And what does it do? It helps in improving the hemoglobin, in improving the platelet counts. The PT and APTT, of course, comes down. And this is not a replacement for either surgical correction, a surgeon's intervention, or a replacement for component therapy. So we need to give RBCs, we need to give platelets, we need to give cryoprecipitate and FFP. And if the bleeding is still not stopped, then consider this off-label use. And this is the overall efficacy. This includes all kinds of conditions. 68% good response with the bleeding stopped, and an overall survival of 76% out of these 188. Now I'll quickly go through a couple of different sites of bleed and how we go about managing it. Severe hemoptysis. Conservative management carries a mortality of 50 to 100% in severe hemoptysis. Mortality rate increases significantly up to 40% when surgery is undertaken as an emergency procedure. And a bronchial artery embolism has been used since 1973. Surgery remains the procedure of choice for treatment in certain conditions such as massive hemoptysis caused by hydrated cyst, thoracic vascular injury, bronchial adenoma, aspergilloma that is resistant to other therapies. Localizing the bleeding site is important. The source of massive hemoptysis is usually bronchial circulation in 90% of the patients, and that's because apart from anything else, the bronchial circulation has got higher pressure than the pulmonary circulation. The findings of a plain chest radiographs are normal or non-localizing. So you can't localize the blood is coming from based on an X-ray in up 17 to 81% of the patients. X-ray is not helpful. The overall diagnostic accuracy of bronchoscopy, on the contrary, in the hemoptysis can be between 10 to 43%. So one can help in diagnosis and localizing. A CT finding can suggest a specific diagnosis in 50% of patients, in whom bronchoscopy findings are non-diagnostic, and in 39 to 88% patients whom chest radiographs are non-diagnostic. So CT is very important. And combining fiber optic bronchoscopy with CT to localize the site of bleed gives the best results. So often in practice, if time permits, we would do a CT and then do a bronchoscopy. So we know where to look for specifically. And in general, if we are able to do a bronchoscopy during a bleed, and of course in this scenario we're talking of massive bleed, it can do both. During a massive bleed, blood may be lying everywhere. I'll take 5 more minutes. Angiographic findings we'll forget. Bronchial artery embolization. The initial recurrence, non-recurrence rates of bronchial artery embolization have been reported in 73 to 98% patients. Long-term recurrence rate is 10 to 52%. The long-term success rates can be improved by repeated bronchial artery embolization. Complications include chest pain, dysphagia due to embolization of esophageal branches, subintimal dissection, aortic branch necrosis, aortic and bronchial necrosis, bronchoesophageal fistula, non-target organ embolization such as ischemic colitis, pulmonary infarction, referred pain to ipsilateral forehead and orbit, and transient cortical blindness. This is a patient who had a massive bleed, and with complete collapse of one lung, we did an emergency bronchoscopy, opened up the lung, patient was hypoxic, had to be intubated, then put a double lumen endotracheal tube so as to kind of isolate the bleeding site. And then eventually we did a embolization, we did an angiography, and then once we found there was a huge bleeding vessel, and they used PTCA wires. They didn't have the exact thing to fix it, so the interventionist put PTCA wires. You can see those dense lesions, those are the wires, and that completely stopped the bleed, and eventually the patient was discharged home, and I have 3 years follow-up. The patient is doing fine without a second bleed. Basic diagnosis was bronchiectasis. Upper GI bleed is mortality 8 to 9%, massive bleed. Upper GI bleed is 5 times more common than lower GI massive bleed. Can present with non-specific symptoms of weakness, sweating, etc. The stool may not show the typical melena 4 to 6 hours later because of slow GI transit in some patients, and it takes more than 100 cc of blood to produce melena. Of common causes: peptic ulcer, esophageal varices, etc. And treatment is put a nasogastric tube. If there is a bright red blood, we need an endoscopy in the emergency. Endoscopy allows triage. If there is a clean base ulcer, watch for 24 hours of discharge. The chances of rebleed is less than 5%. If a clot is or a visible vessel is seen, rebleeding chances are 12 to 20%. So such a patient needs to be admitted and kept under close observation. Endoscopy decreases the need for transfusion and decreases the need for surgery. And various interventions have been tried, including electrocautery, clipping, injections, banding. You're seeing an example of banding. Combined treatment of various modalities, argon plasma coagulation, fibrate sealant to stop the upper GI bleed. Surgical management consists with endoscopy. You can see 1 out of 25 bleeders which cannot be stopped would require surgery. And as a rule of thumb, if more than that's wrong. If more than 4 units of RBCs are required, surgical consult is indicated, mandatory. May need a surgery. A lower GI bleed is any bleeding from a source distal to the ligament of teats, and various causes including diverticulitis, AVM, neoplasm, IBD, uncommon ischemic bowel disease, etc. As many as 11% of patients suspected initially to have lower GI bleed are found to have upper GI source. So we need not forget the upper GI as a source. Melena is present if bleeding site is proximal to the mid-transverse colon, and hematochezia is present if it is seen in case of bleeding distal to it. Endoscopy again has become very important, and after a rapid oral purge, it can be diagnostic in as much as 89% of the patients and therapeutic in 20% of the patients. A combination of overall diagnostic yield and a low complication rates make colonoscopy more attractive than angiography. And of course, it can be therapeutic by using multimodality probes, such including heater probes, bipolar coagulation, etc., or injecting stuff like epinephrine. Endoscopic hemostasis may prevent recurrence in bleeding and reduce the need for hemicolectomy. And massive diverticular bleeding may not be amenable to endoscopic therapy due to poor vision. Angiography is another option and may be appropriate as initial diagnostic test in patients with massive bleeding that precludes colonoscopy, or after a colonoscopy fails to localize or fix the bleed. A bleeding rate of 0.5 to 1 cc per minute during angiography is generally required for positive results. So false negatives are possible. Intra-arterial injection of vasoconstrictors like vasopressin have been used with a complication rate of 10 to 20%. And transcatheter embolization may help sometimes. And surgery may help in some scenarios. I think I'll skip PPH. Just remember this slide, hemostasis. The acronym is pretty interesting, that more or less summarizes the entire discussion. There is a worldwide study which is started in 2010, looking at tranexamic acid as part in randomized controlled trial for PPH, and of course factor 7 we have already spoken of. This is the Indian experience with factor 7A, Novo 7, 10 patients in 3 hospitals in Hyderabad, a very small number. 9 out of 10 cases ended up with hysterectomy despite the use of the drug. Thank you.